distributed, and hopefully everybody has had a chance to look over them. And I'd like to ask first if there are any additions, deletions, or corrections to the minutes as we have distributed them. Hearing none, I'll take a motion for approval of the minutes of the meeting of July 15.
I'll motion to accept them.
And a
Second.
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 All in favor, I think we can do this by voice vote. All in favor?
Aye.
Opposed? Thank you.
Question for Mr. I'm sorry, question for Mr. Morton. Because this is a virtual meeting, do we have to do roll call votes for everything?
You know, I think you're right, Doctor. I think you do.
Okay. Well, let's
Yeah,
do that then. So Nora, if you'll run through the roll, sorry about that. If you'll run through the roll, we can do
No worries.
that.
Yes, sir. Drake,
Yes.
Gotcher,
Yes.
Hurt,
Yes.
Jacobs,
Yes.
O'Brien,
Yes.
Shemaya,
Yes.
Sousa,
Yes.
Wagner.
Yes.
Thank you. Unanimously. Thank you.
Thank you very much. Next order of business will be our benchmark presentation. And Dr. Buchanan, if you will, if you have the, I'm sure you have the information, if you will lead us in that, please.
Sure. Catherine, if you can share your screen and so everybody can see the benchmarks as I talk through. So while she's doing that, I'll bring you up to speed quickly on where we are in the county. We have 2,550 confirmed cases of COVID in Knox County, with an additional 117 probable cases. 1,102 of our cases have recovered, giving us 1,392 active cases. 171 individuals have been hospitalized at some point in their illness. 38 Knox County residents are currently hospitalized. And sadly, we're reporting another death due to complications of COVID-19, bringing our total to 21. Certainly that's a sad thing to have to report, and we're reporting that more frequently these days. And just as a reminder, for the majority of our benchmarks, what we want to see, what we're looking at, what we want to see is no 3-day statistically significant shifts within a 2-week time frame. So we're looking at that every day, and we look back at the previous 2 weeks, which is what a rolling average is. And this information is available on our website for the public to see whenever they like. But these benchmarks are only updated weekly on Wednesdays. So the first benchmark, which you see before you, is sustained reduction or stability in new cases for the 14 days. And if you've been paying attention, you know that for this benchmark, we have seen consecutive days of red flags and a significant continuous increase in new cases. This causes us to represent this traffic light as red. This is certainly a concerning trend, and one that is causing us to approach a new normal for cases, but this is not a new normal we want to continue, this large increase in cases. And really points out that this virus is still very active in our community and increasing at a high rate. Our second benchmark, community-wide sustained and increased diagnostic testing with consistent or decreased test result reporting turnaround time. So we have 2 graphs for that one. The first one is the testing being conducted, and as you can see, the trend line for testing continues to be in a positive direction. So even though it went down a little bit this last week, the trend is still up across the county. And for the second graph, we're looking at turnaround time for labs. And this is kind of flat, if not but maybe decreasing a little bit. You've heard us talk about our concerns about test turnaround time due to testing supplies, sheer volume of tests, and taking so long to get back. That Knox County Health Department certainly has experienced with the lab we're using some significant decreases in turnaround time, or increases, excuse me, in turnaround time. So when we look across the community and knowing all of those pieces of information, we are representing this as yellow just because of the concerns about lab capacity and turnaround time that exist across the community, not just across our community, but across the state. So representing that at yellow. And as a reminder, for the tests that we can see, and that's the other part of this, when we look at this data, testing represents just a sample of the tests being done because it's only the tests that we can see. And the system for that, for pulling that data out is rather complicated and not always as clean as we would like it to be. So we're really just looking at those trends. And we are only doing about 16% of the testing that we can see across the county. So we don't represent a huge portion. 84% of the testing done in the county is being done by other providers, which is actually something we want to happen because people need access wherever they are to testing. So we're happy about that. Our third benchmark, sustained or increased public health capability. For this benchmark, we aim to reach out to cases within 24 hours and close contacts within 48 hours. And to date, our team has been able to accomplish this for all cases and contacts. Because of that, this benchmark continues to be represented as green. As you can imagine, with increasing cases, this goal is getting harder to reach. We actually have staff beginning work at 5 a.m. to start pulling the data from the labs to start the process of getting that worked, and working 7 days a week to reach these goals. So we're staggering staff, having staff start work early to get things rolling so that when we all roll in around 8 o'clock, we're more ready to go and start calling those folks. So we continue to build our capacity. And you'll notice that the team numbers, if you look at our team numbers, if you know what we had last week, it grew by 26 from the last time we reported this. And what we've been doing is cross-training all of our staff to provide that 7-day coverage so that we have weekend teams to give folks who've been working weekends consistently some time to not have to work weekends. So that's been a welcome relief. In addition to that, the Tennessee Department of Health is doing some contact and case monitoring for us. And we can't really represent that capacity in our numbers because we just don't know how many of those folks are helping serve us. But that's helped tremendously in this capacity. So proud of our team for being able to do that, and hope that we can continue to do that. Our fourth benchmark, healthcare system capabilities remain within current and forecasted surge capacity. These graphs show the availability of regional hospital beds, ICU beds, and ventilators for our hospital partners across the region, not just in Knox County. I'm sorry. Okay. It also shows the additional surge capacity for these categories, as well as the COVID positive patients and patients with pending tests in the hospital. This data is gathered from the Tennessee Healthcare Resource Tracking System, or HERTS. It may reflect Knox County, East Region, or patients from other jurisdictions. So again, not just Knox County. We make the decision about this benchmark in consultation with our hospital partners, who these days we're talking to about every other day, if not every day. And this benchmark continues to be yellow. The hospitals continue to be able to manage the surge of COVID patients and the surge of not the surge, but the volume of non-COVID patients adequately. We did experience some statistically significant increases in positive patients, ICU patients, and ventilated patients. But again, after speaking to the hospitals, we kept this at yellow for a second week in a row. And as Dr. Shamia is very aware, our hospital partners are meeting very regularly. Actually, I think they're having daily meetings down to talk about capacity, and so they're working really well together, which it benefits our community greatly. And for our fifth benchmark, sustained or decreased COVID-19 related death rate for identified positive or probable cases. As we mentioned last week, we've been working on a new way to represent this benchmark. So yeah, we have that. That's the new way, isn't it? No, sorry. So moving forward, this graph is going to show the reported deaths of Knox County residents by date. That appears to be what? So, okay, it is there. It's there now.
It used to be a table.
I apologize. It used to be a table. So this benchmark is continues to be in red because we've had statistically significant increase in deaths. 55 of our deaths from COVID have occurred in the last 55%, not 55. 55% of our deaths from COVID have been reported in the last 14 days here in Knox County. So that's obviously a concerning number as well. So, you know, we had only 5 for so long, and now we've had quite a few in the past 2 weeks. So, Any questions on the data or the benchmarks?
So, Dr. Buchanan, back to benchmark 2 and 3. I don't know if we can scroll back there. So obviously, turnaround time and then the ability to do the contact investigation are very much related. So, I mean, you could have 5,000 people doing phone calls within minutes of a top positive test result. But if that test result took 7, 8, 9, 10 days to get, it's ultimately not effective. And so it's not within your control. I mean, you guys are doing everything that you're able to do. But I did want to understand first on the turnaround time, just to dig a little bit more. So you said you do 16%. You're the one sending 16% of the test in the county. And so, but this data represents all of that 16% and then some portion of the rest of the testing that's happening in the community. But as to how much of that portion it is, we don't really precisely know. Can you help me with that just a bit?
Sure, we don't. You're absolutely correct. So the 16% that we do, we sure know about that. Go ahead.
Oh, can you scroll up a little bit? I have the box.
The 80 something percent that is represented in the rest of this is really just a sample of what's being done in the community. And part of the problem with that is that we can't see what private providers are doing, and the way this is being reported, positive tests. There's a great system for positive tests to be reported to public health. We feel comfortable with positive tests. We know we're getting those. The idea of reporting negative tests to public health, so we know the full volume of people who are being tested for disease, is new. And this was a decision made during this pandemic to do that. The system for reporting those negative tests is not standardized, and it's not as reliable as the system for reporting positives. There's less information that's required for reporting negatives. What we found in the data that we get from the state is that sometimes the address will be the lab or the doctor's office where the test was done, maybe not the person's home. So if you have a lab in your region, your volume might be artificially high because it's the address of the lab. And so those things are contributing to the lack of clarity on that data. So that's why we say it really is just a sampling to give us an idea of which direction testing is going in.
But okay, so perfect. And so then my follow-up question on that is that, but you are hearing about every positive test. Can you hear me? Okay.
What was the question? I'm sorry.
So no, you're fine. So you are hearing about the positive test, obviously.
Yes, we feel very comfortable with that reporting system.
And so then you have a sense of what the turnaround time is, certainly for the ones that you're hearing about. And so I see on the lower graph there. So I mean, are we no longer seeing these 7, 8, 9, 10 day turnaround?
I'm gonna let Charity take that.
Okay, perfect.
She's in the room.
Hey, yeah, so there's enough of the kind of same day testing being done that's balancing out. So this metric is really focusing on, accessibility in the whole community. So, on the upper graph, the 3,500 tests that I think or so that we can see right now this week, or for July 12th through 18th. So all of those may not be back yet because of the lab delay, which was one of the reasons we made that a yellow, but we're about 16% of those. We know that our lab delay has been, around 11 days or so for that 16%, but there's the rest of that is being looked at for all of those other, whatever 16% of 3,500 is. I'm not going to do public math, but that's being balanced out. And so, the testing you guys are doing in the hospitals are a lot of times turning around quicker. The ones that are being done, the rapids being done at walk-in clinics, for example, are in that number. It's not all of the tests, but we are looking at the overall community picture there on what the average time is. And it does balance out to be that average right now of those, like I said, 3,500 or so for that week. That's the average that we can see. We just know not all of those for that week are back yet, at least from our perspective. Does that make sense?
It does. Yeah, I just would wonder that, I guess, anything that we need to hear about I know, so it's an average is helpful, but for whatever that subset is, where it's still several days, if what the next options are to try to remedy that, if that's part of the 16% that's within your direct.
I can
Not
talk
your
about-
control, because you're not in control, but just the ones that you're doing the tests for.
So what we are doing to problem solve that is we are actively pursuing some emergency procurement options with other laboratories that have a quicker turnaround time. So basically, we're increasing our portfolio of laboratories we're going to use for testing. And we actually had a couple of labs we were using for testing, one of which, because another vendor had a higher volume, they told us they can no longer support us. The other of which is having a lot of turnaround problems with reagent issues and other things. So we're expanding our portfolio of labs that we're using. And we're also pursuing some other options for this week. Tennessee Department of Health lab here in Knoxville is going to support us and do our testing for us. They can't do that ongoing, but in this situation, they were willing to do that. So we think they have a 24 to 48 hour turnaround time right now. So we're happy with that. So we're actively pursuing that for the people that we're serving. And if a provider has a problem with turnaround time in lab, I'm not sure, we can't really help them. And I'm not even sure if TDH can help them with that. Labs are moving around and having to adjust based on volume and capacity. They're building their capacity, but I don't think they can build it fast enough to keep up with the demand.
Okay, thank you.
Thank you.
Dr. Buchanan, sort of a follow-up to that. Do you have any information as just, or maybe even just some suggestion of the difference in turnaround time between the health department and in the community? Is it less in the community or is it longer in the community?
You'd have to, I'm going to defer to Charity again.
And I honestly don't have a great answer. I think it varies. We can maybe hear from some of the hospital folks on some of the labs they're using, but we are seeing everything from, again, this kind of same day turnaround time where they test positive that morning and we get the test results in a couple of hours, or and then ours has been kind of the long end of the spectrum. But I'm getting a text right now. I'm hoping to be able to answer from our Epi in a minute if there's more specific. But I mean, I think that's where you can kind of gauge with what the balance is, where you look at, we're at about a 4-day average right now, where we know our end is about 11 days. So so that's definitely going to skew it down. That means there's less days for most of the folks out there that are having for their turnaround time across the community, from what we can see.
Thank you.
Sure. Any other questions about the benchmarks?
Just sorry, I have a lot of questions, but just on benchmark 3, yeah, I understand clearly based on what you said why that one is a green. Now, just based on this pace of diagnosis, and I've got slides that I can go through in just a second, very similar to kind of the same format as last meeting. But I guess I don't know how much they're going to be able to continue to give you more people, but it would just seem to me it's just a matter of time where the volume gets to be more than what we can contact trace. And so, I mean, do you have a sense that, are you concerned about that? I understand it's green today. That makes sense, but just going forward, what do you expect?
I am concerned about that. Our goal is to keep this benchmark at green, and we had 4 contracts for staffing agencies on county commission that will be approved. That's what part of what that $7.1 million we got from TDH will be used for, is paying those staff to add to the staff we have, in part so some of our staff can go back to some regular operations, but acknowledging that we're going to have to keep a lot of our staff involved in this process as well. You know, we had a vision of being able to step away from this a little bit, but the reality is we're probably not going to be able to. We're probably going to have to keep some staff engaged, maybe not as intensely as they are engaged now, But we'll have to keep our staff engaged as well. I think that's just the reality of where we are as far as our case counts go. But it still could outpace us. It could still outpace us. And, today we had,
Yeah, I was gonna say, just to kind of give a little perspective, the numbers you'll see tomorrow is gonna be a large jump. I think they worked about 188, 190 cases today that you'll see in the numbers tomorrow. We had probably 24, 25, I think. I'd have to go back and look at the exact numbers, investigators assigned to work those cases. It might have gone up a little bit, but not a lot. And then probably 6 or so, there might have been a few more we added data entry people. So my point on that is you see 166 people on our team. That's to cover 7 days a week and the sheer volume, and to let some people do some other work here and there. But it's, probably, I would say 30 to 40 people working per day right now, meeting that volume. So just to kind of get that perspective of where we are.
and the state doing our contact and case monitoring, that's huge.
And there
That
actually
means-
is now some contact tracing that they do for us as
Yeah,
well, to
so-
do that centralized process. So some of that burden has also been taken off. So that I don't think that it's going to be in the immediate future that we're running into issues. We're concerned about it. Absolutely. We need more staff to do this so we can do other public health things. All of that stuff's very important. But we also are, I think, well suited right now to meet the demand. It is a lot of demand, and it's a lot of long hours for those people there.
Thank you.
Any other comments or questions on the benchmark discussion?
Dr. Gocher, from the hospital capacity piece, I don't know if this is the appropriate time for me to present slides as I did last week. You just have to tell me from a matter of procedure when that time is.
Dr. Shamay, I think it would be fine to cover that as UT sort of portion of that whole benchmark discussion. And then it could also be done in other business, but that's the next topic up.
Okay.
So why don't we just transition into that if you have that available?
Yeah, I believe somebody's going to run that on that side. Is that correct? Okay. All right, great. So what I've tried to do is get everyone used to seeing really the same format of data week to week. And so this is actually a little bit shorter than what I presented last week, but you'll see a lot of the same things. And as we go week to week, you'll be able to remember what we looked at before, and I'll even reference what I've shown you before. And so next slide, please. So this is, and I'll also call out that the vast majority of this is either Knox County or it is what the THA, Tennessee Hospital Association, defines as the counties in the Knoxville district. There's a few of these, again, because it's the only way I could get the data that I've gotten data from UT Medical Center. And this is one of those. So this is UT Medical Center data as of July 21st, since we started diagnosing COVID. And so what you see, and we looked at this last time, is on the left are everyone that we have tested positive by age group. And on the right are the hospitalizations by age group. And so the thing that I've put it side by side, I point out is that there has been a shift overall there is the presence of diagnosing younger patients. On the right-hand side, you see it shifted more to the right, where hospitalizations tend to be in older patients. But still, I point out that 20 to 30, 30 to 40, 40 to 50 age range represents a significant amount of the overall hospitalizations. And I think that the feedback I got was that this was, I mean, the sense I got was that this was helpful to see the age distribution. Next slide, please. So we looked at this. This is looking at the rate or as cases are diagnosed, how does it relate to hospitalizations? On the left is Knox County, and on the right is that THA district, which I have that on a slide, but that includes Knox, Sevier, Jefferson, Hamblin, Union, Anderson, Blunt, Cock, Granger, Claiborne, and Campbell. So the actual correlation here is very similar to last time. In Knox County, it's 48 new hospitalizations for every 1,000 new cases. The notable thing about this is that if you see those circles, it's kind of inflecting left and right. So it's not as precisely smooth. The relationship is still very strong, but I think it'll be very notable to see next week whether it inflects back upward or whether it starts to level off. I can't say at this point. However, on the right-hand side, which is Knox County and all those surrounding counties, it's still a very pure line to see that we still seem to be able to predict with some degree of certainty how many, each 1,000 cases, how many hospitalizations that will be. And, you know, I want to emphasize the reason why, from a hospital perspective, why I'm also talking about the Knoxville district. I've made the case on every meeting that I think hospitalizations are the purest thing we can look at. And because a lot of this conversation ultimately becomes about the capacity of the healthcare system to be able to take care of these patients, I think it is important to know that I mean, when I think about hospital capacity for all of those counties, I think of it as if it was one big hospital that was serving all those counties, because ultimately we're working together to make sure that we can serve the need, but we're affected indirectly by all the counties that are around us and from a healthcare perspective. Next slide, please. So this gives us the pace of new cases, and this gets back to my question about contact investigation. Remember, it took us 81 days to get to 1,000 cases, 17 for the next 1,000, 8 for the next 1,000. And I don't think the data was quite out today, but it was projected that this most recent increment, it took us only 4 days. We'll see if that's projected. It's not been reported yet, but at the pace we were, 4 days to get to that next 1,000. But whether it's 4 or 5, we are adding 1,000 cases every few days, essentially, at this point. Next slide, please. So this shows you both the Knox County and the Knoxville district by week and by month. And I showed this last time, but you just see how much July, just to date, is outpacing June in terms of the new cases. And then you see it by week. And then you can see that we don't yet know what that next one will be, but I think that the next spike, it's really inflecting upward more and more. And the reason from a hospital perspective why I showed this is that slide that talked about how this translates into hospitalizations. Next slide, please. And this shows the same thing as far as hospitalizations. And in the same way, when I showed Knox County and how the line kind of, it wasn't, the round circles weren't exactly straight, but they were wandering. Here you see that the Knox County hospitalizations, and again, these are people with an address in Knox County. It's not about where they were hospitalized. Isn't that right, Dr. Buchanan? Yeah, okay. That's generally what the Knox County data is. And so that dropped from 29 to 20. But if you see, again, all those counties, that surrounding district, that we're still on the increasing side of hospitalizations. So that's the trend. Next slide, please. So now this should look familiar. It's been updated. So this is all of those counties and the inpatient census on each of these days. This is the total number of people that were in the hospital across the hospitals that serve these counties. And you'll notice on the right-hand side that it went from 143 to 128. So there's that notable dip in the upper right. The point I want to make here is that we're not, based on what we know about the reporting, we're not certain that that's a real dip, in that all it takes is a few hospitals. That represents 2 days. And if you don't get daily reporting from everybody, you'll see some variance in the data. And so while that may represent something, I think we'll know better next week what really is happening there. Next slide. I'm on the home stretch now. So this is, if you'll recall, this is exactly what I did last week. I just took what has happened up to now and then projected it from a hospital census perspective to September the 9th. And this is not some fancy modeling. It is just taking the trend that we're on now. And if all things stay equal, nothing changes. There are assumptions there, but it just projects that out to September 9th. I think the next slide will be even more helpful though. So what this is then taking what we looked at last week and what we're looking at this week. So what we looked at last week was the blue, and then what we've added in the last 7 days are the new projection, the new data and the new projection is the orange. And so you can see on that September 9th, they've landed pretty close. Our projection is just slightly lower this week than it was last week. But I can say that across all of the hospital systems, certainly 363 patients in the hospital at one time who were there because of COVID-19 is a significant amount of patients for the healthcare system. Dr. Buchanan mentioned, but we're having daily capacity calls at 1 o'clock where all the major systems are together. Just really, what is the sense of where they are with beds? We flipped from being very ICU heavy, and then the ICU seems to not have as many COVID patients, but then the acute care side does. And every hospital may be different in how that's happening. And so we think there's value to us sharing that on a daily basis so that if the need arises, we can help each other. But even with that, that's a significant number of patients on September the 9th. And so would very much like to see that. And as I'll show you each week, we'll see if it starts to flatten out. We'll see how accurate it is. That's the whole point of not just looking at it once, but looking at it every week. Next slide, please. And I believe that's it. So be happy to answer any questions about that.
This is Maria Hurt. I have a question.
Sure.
And it's simply, and I believe we brought this up last week as well. So, and I realize this isn't a fancy model. It's just based on what the trend we've seen so far. But it's not that encouraging. And my question is there any way to anticipate how this data might change once school starts, not only elementary and high school, but of course, University of Tennessee? I mean, common sense would tell me that the numbers probably aren't going to get better when those institutions open. But I'm wondering if you could shed some light on thinking or anything about that.
Yeah, so I mean, the short answer is that we don't know. And I do think your intuition, just understanding how COVID-19 behaves, I would agree with your intuition, but I don't know. I keep getting back to the 5 core actions, and whether it's somebody's household or whether it's a school or whether it's a university or a business, or it does not matter. If those can really be followed across all those different things as things open up. I mean, I think the thing we've learned here is that if you open up with 5 core actions, and you open up with them as to permeate every aspect of society as much as possible. And that's not just from a public health perspective. To me, that's from an education perspective. It's from an economy perspective. It protects everything. And so while I can't answer your question, what I can say is that the more all those segments of society follow those actions, then the less it will alter that curve in the negative direction. But it is a concern.
One comment I had, and this was looking at a study that just came across my desk about a day or so ago out of emerging infectious diseases. And I ran into it because it made the news. And Dr. Chimay, you probably know about this study, but it came out of South Korea and it involved contact tracing on index cases. And they looked at 5,700 index cases. So it was a pretty robust study. And they looked at 59,000 contacts of those patients. And what they found was if they looked at household contacts of those index cases, that about 12% of them became positive. But if they looked at a subset of people that were 10 to 19 years of age, that about 19% of those were positive. I guess the take-home lesson would be two things. One is that age group can certainly spread the virus, and that they tend to infect at a slightly higher rate in their own homes, at least. So the implication for schools is that that group of people is certainly not at all resistant to spreading the virus.
So any other questions?
I'd like to say something tangent to what you've each addressed. In terms of observing the 5 core actions and education, I am, I am assuming my fellow board members, doing my very best to read all the emails from concerned citizens on either end of the spectrum and in between, and their opinions of what we should or shouldn't or can and cannot do. Something that I would like to talk about, and this may be the time or it may be further in the meeting, but many people are concerned about observing and experiencing their fellow citizens not observing the core actions, including I've read several reports of people sharing a misunderstanding. Now I'm saying let's leave judgment aside of who can or cannot or should not, let's say, wear masks indoors. But there does seem to be a certain amount of misunderstanding of opting out of wearing a mask in indoor places if people can promise to keep physical social distance. And of course we know, and we've talked about as a board and all the literature shows, you can't always anticipate when you're going to accidentally be within less than 2 meters or 6 feet of someone else. And we know that that's even harder in a retail environment. So I would like either now or at some point in the meeting for us to talk about and explore how to address that, how to address the lack of understanding of what the regulations that have been put in place are meant to do, and what the parameters are, and how we can move forward in making sure that all segments of our city and our county have an understanding about those 5 core actions.
Dr. Hurt, that's really well thought out input. And what I would like to do is to address that, but I want to do one thing first, and that's as we leave the discussion of benchmarks, to make sure that there are no other questions or discussion about the benchmarks. And then when we go to the next item, which is other business or future business, let's take that up right off the bat. So any other discussion about the benchmarks, questions, concerns? If not, we can go to the next section.
I don't have a question or discussion about the benchmarks. However, I believe we have another agenda item, COVID-19 face covering regulation review and discussion, which we said would be part of this meeting. I believe that's after the benchmark discussion. Dr. Gocher, you're muted.
Oh, sorry. Any other discussion on benchmarks? If not, we'll go to the next section, which is the COVID-19 face covering regulations review and discussion. And Dr. Hurt, your comments, dovetail right into that. Further discussion on your point.
I have
Sorry, go ahead.
go ahead. No, go ahead, Marcy, please.
So I guess I just had a question with, I know that I've brought this up last week as well as, I guess it was last week, that we're certainly seeing more people wearing masks across the county. And, but certainly, as Maria said, we get lots of emails on either end of the spectrum, and a number of those have been that there doesn't seem to be as widespread coverage in some areas of people wearing masks as we would like. Is there any way that we could, I guess, just get some feedback from maybe the city, the county, the health department as to, and I think that we talked about that incremental enforcement where we're trying to encourage people to do the right thing by giving them masks and not necessarily the citations, because I think that we all agree that we don't want to give people tickets and throw them in jail, but see what sort of actions are being taken out there in the community to educate, as Maria mentioned, as well as provide masks if that's something that someone is lacking.
So I can speak for the county, and we could certainly have somebody from our environmental health division, who is our regulatory division, who is out there in the community, observing, educating, providing information. Provide that information to you. I don't have any details. I know that we get a lot of complaints, and most of our complaints are about people not wearing masks at a store or a restaurant or wherever.
Okay.
And so I had that number.
And I guess, Dr. Buchanan, I'm not saying right now that you need to scramble and find them, but maybe next week, if we could have maybe a brief report from each of those entities and kind of what efforts they've been doing, and are they encountering a lot of problems? Where are they seeing problems? How many citations? How many masks have they given out? Things like that, just to see, are we doing a good job of educating our folks and providing them with the equipment they need?
Yeah, so we can get that from the city and the county, because for the places we don't regulate, the city is doing that, helping out with that. So
great, yeah, that'd be awesome. I think that'd just be good information to know how we're doing.
Sure.
Thanks.
It would be good also to break it down. Who's helping in this process between city and county agencies? Who's being active versus who's being passive? So I think that'd be good information to know, and to encourage everybody to help us along the way to get that message out and be consistent across all agencies, city and county, to do that.
We can do that.
I would like to clarify one thing that I'm not sure I was clear about. The feedback I've read about people sharing in their emails is not complaining about individual people in restaurants or retails, but actually business owners who are not enforcing this law, this regulation. So it's a larger problem than just individuals, but people who have the power, because they're business owners, to educate, if nothing else, to say, please, wear a mask, and here's why we want to protect each other. So I wasn't sure I was very clear about that. I wanted to make sure I was.
When we're looking at the education front, I think there is, there's all sorts of issues going on here. You guys are getting emails. We're getting tons of emails. The mask mandates, very divisive. Talking with my colleagues around the area, it's extremely divisive. I have some questions myself, and I have some questions that have been submitted, and I would just like to present those to you all so we can maybe clear the air about some of this stuff and really help folks understand what is the science behind what we're talking about here. So if that's okay, could I go ahead and, Dr. Gocher, could I go ahead and ask a few questions, please?
Sure, go right ahead, Mayor.
Thank you. And the first one is just from a media and a historic aspect here. A few months ago, Dr. Fauci was on 60 Minutes saying people don't need to wear masks. Then the Surgeon General, people don't need to wear masks. WHO, people don't need to wear masks. The New England Journal of Medicine came out, same thing on May 21st. What changed? Now masks are imperative that we all wear. And a lot of folks are pointing back, well, 2 months ago, they weren't even talking about this. And then it became a recommendation that became extremely important. So what changed in that area?
We learned more about the transmission of this disease, and we learned about how masks can be protective of others if they are worn by looking at the data from other countries where masks were worn and how that helped reduce the number of cases. So, we're learning about this disease on a regular basis, and the science science didn't change. We just learned more about how this disease is transmitted, and I welcome any. And also we learned a lot about asymptomatic spread that we really thought in the past was not as big a deal, but it's a real thing. People aren't sick and they can still spread this disease. And we know that masks work in the hospital to reduce the risk and to reduce spread of disease. So
well, I guess that'd be the next question. We're talking about normal people, not medical professionals such as most of you, wearing a cloth mask in an uncontrolled environment. And what are the studies and the indications that show that that's effective?
I know there's at least one study from South Korea. I'm looking at Charity, and a couple of others that I'm aware of. Dr. Shmi, I don't know if you know of any studies for general public wearing cloth face coverings. I know they're out there.
Not specifically, but to speak to the virus itself is that what we do understand is that the mechanism of transmission is through droplet spread, and then the point you made about asymptomatic. I mean, this is unusual for a virus to behave this way, and we didn't know this back in March. And so as much as I'd love to be able to quote 25 studies that looked at
no, I understand.
made out of bandanas. Right. It just makes perfect sense when you understand how the virus transmits, and you understand the fact that it can be in an asymptomatic individual who can still be shedding a good bit of virus. It doesn't have to be a medical grade mask. Right. It's just a barrier. It's a barrier enough to prevent that from getting out into the immediate vicinity of a person. And
True.
So
droplets, which can be spread either coughing, sneezing, or talking. And talking is probably the big issue, right?
Yeah.
Right.
I mean, just one more. We've seen so much when people eat together. And so that's, a lot of this about education is just, and we've heard those stories about how somebody has their guard up 95% of the time. And it's that 5% when they caught COVID. And so if you think about it, you're sitting with somebody eating, talking, nobody's wearing a mask when they eat, you're not 6 feet apart. That's a risk point. And so I'm sorry to
No, thank you. And I guess that would bring up my next question. If this is a barrier, and there's a proper protocol for putting on the mask, right? You're supposed to wash your hands first, put the mask on. You're not supposed to touch your mask. Is touching the mask a problem, taking it down, putting it on something? And we all do that as well. When you take it off where you're supposed to keep it, everybody just kind of, that I know anyway, throws it in their car. Can that inadvertently cause problems, either, through the spread of the virus itself or other hygiene problems?
So part of that is, what's in your mask that you took off of you are the germs that are coming out of you.
Right.
So you'd have to put it on somebody else's face.
Now my question, Dr. B, is it possible for the mask to end up transmitting?
Not to another person?
If you sit it down on something and then someone else touches that, we talk about, like, I've been like hyper vigilant about sharing pens because they're germ sticks, right?
I think the more important thing is about hand washing for everybody. And that's why you need to wash your hands all the time. And, it doesn't live on surfaces all that long if it were to be in the mask. So
Sure.
I was about to say the latest coming out from CDC, and there's been a lot of coverage on this lately, is the primary method. Oh,
you need to unmute. They might not be able to hear you.
She wants to show me. The primary method is really that droplet, that close contact with somebody getting the droplets. the fomite spread, which is what you would be describing there, picking it up off of a surface. It can happen, but it's not, from the body of evidence that's out there right now, that is not the primary method. It's that close contact, getting the droplets directly at you, which is where the mask comes in as a benefit. That's the latest that's out there right now. And with I believe a lot of the supporting documents and the CDC decisions on some of those things with masks and some others.
Thanks. So we should also be encouraging proper, when we're talking about the mask, cleaning it, making sure that we aren't reusing it, all that sort of stuff. Correct. And also, one of the things that I've seen and witnessed is now that we've put emphasis on the mask, I think a lot of people are no longer observing social distancing as much as they were previously. People are getting closer together. So I think also when we're looking at the 5 core actions, we need to emphasize all of those. And you know, we've talked a lot about the mask, and I understand, you know, it's important, but I think now some people are, you know, they're looking at the mask and, well, I wear the mask and just go back and do back anything I want, and then, you know, end up in that close proximity, which can be problematic. Correct?
I think it does let people let their guard down a little bit. I think the more commonplace people let their guard down is in that familiar location that Dr. Shamia was talking about. You know, you're in the grocery store and you run into your friend that you haven't seen in a couple of weeks. And, you know, that's your friend, and you're going to have a conversation with them, and you don't put your mask on, or you don't have your mask on, and you stand there and talk for 20 minutes and don't realize you've been there that long. And again, that's an exposure. But I do think, and I think talking about all of those 5 core actions and the important role they all play in protecting us, you know, from COVID and lots of other things.
And one last thing that has been a concern of mine in my office is we're seeing groups pop up online on Facebook that are shaming folks that aren't wearing masks. And in many cases, they don't know why those people aren't wearing masks. In one instance, we had a mother call this office, and she was expressing her frustration because she had been refused service at a number of stores because she wasn't wearing a mask. Well, it turns out her son is autistic. He can't wear a mask. He freaks out whenever she wears a mask. And that just is causing her a lot of problems. So as you talk about a lot, Dr. B, I would encourage folks to not judge people and to realize that in some of these cases, folks have legitimate reasons, medical or otherwise, why they can't wear a mask. But those folks should also still observe the other key areas as much as they possibly can. Thank you. Thanks, Dr. Gotcha.
I
Thank
would
you.
just like to say I appreciate your the short video you made. I think it was a couple of weeks ago, Mr. Jacobs, about, you know, everyone refraining from judging, because there are also groups of people who have, and I've seen this on Facebook, who have made a dedicated effort to professional ways to shame people who are wearing masks. Right. And so those extremes really aren't productive, and it's best if we all focus on helping each other and offering each other a little bit of grace. But education is key. And so that's all I want to say about that.
I think we can all agree this is one of the most frustrating things that I could possibly imagine. And we're all just trying to do the best we can. So I absolutely agree with you, Maria.
So one quick comment about the education part. This is rapidly evolving. You know, the science is evolving, not really changing, but we're just learning more every day. And there are a number of people that I have talked to or tried to counsel that were very concerned about wearing a mask or not wearing a mask. They got their information off of a .com site. Some of these were conspiratorial in nature, that sort of thing. And I would just caution folks to try to look at this information as critically as possible. One thing that I've counseled people to do is to look at Cochrane evaluations, or to look at the higher level scientific literature, scientific journals that have a high impact factor, ones that are widely known, because they probably have the most reliable information. It's really difficult to sort this out. I mean, most of us spend our whole careers trying to winnow our way through scientific literature, And it's easy to latch onto something that sort of fulfills your prejudice or fulfills your idea about something, but it may or may not be true. So there's a lot of caution that needs to be exercised in reading headlines and looking at scientific literature superficially.
Jack, could I bring up one thing just for a second that I've heard
Sure.
or have seen and heard from people? There's been some of the letters have been asking us that have been sent in the emails about, where are these cases coming from? Should we, we need to shut everything down. We need to just, tamp down real hard on things so we can kill this thing off. We've got to have a balance between what we have to do in the way of mitigation and, keeping the economy going. The good thing is, in talking to the health department staff and looking at some of the data, thankfully in Knox County, we have not had clusters related to restaurants or businesses at this point, it seems, and that's a positive. So on average, it sounds like most of our restaurants, most of our businesses are going along with this. Yes, there are outliers. There are some people who still think nobody's going to tell me what to do. But things look good in that regard. Where the problem comes, and I have seen this personally, is where somebody lets their guard down and they get together socially and they decide to have 20 friends over in the backyard and have a cookout, or having some sort of other social thing related to a birthday or whatever. And that's the time when this is becoming a concern, that we're seeing a few cases or more cases coming from private gatherings and occasions than organized businesses or other things. So I want to just really encourage people to, don't let your guard down. Just because your next door neighbors are your best buddies doesn't mean they can't spread the disease to you and to others. And so, or if you're having a birthday and you decide to bring people in and nobody's wearing a mask. I have personally seen one gathering of 20 some people in their 30s and early 40s who didn't do any social distancing, or in fact, none at all. And they just said, we're used to being around each other. Well, being used to and transmitting disease is easier to do in that case. So I want to just encourage people, be careful when you enter into those familiar situations. And please, just again, the 5 core things, and do all of them, please.
I believe Charity has something to say.
Yeah, I was just going to echo that. Talking to our staff, and I mean, my office, I can hear people doing interviews every day, all day long, from my office, and that is exactly what we're hearing a lot of. And I mean, it's the social gatherings and getting together with people that you feel comfortable with. They're my friend. They look healthy. They're fine. All of those things. It happens in the workplace too. So we have had clusters in workplaces. And a lot of times it's the same thing. People are around them every day, and that's when guard gets down. So the public facing, we're not seeing a lot of clusters with patrons of restaurants or stores,
Right.
or that kind of thing. It's the co-workers that we do still see them in. And it's the same exact situation as the dinner party or the baby shower, or going out with your friends to the lake. All of those things. It's that the thing that Dr. Shamiya brought up last week, and we've already talked about today. It's that letting the guard down with the people that you're around frequently, where we're seeing a lot of concerns about. That's where people aren't following all the core actions for the most part, and we think that we're seeing a lot of spread thanks to that.
And a little more anecdotal, but we've also seen, one of the 5 core actions is staying home if you're sick.
Oh, yes.
And that includes not going to work, or to that baby shower, or wherever it is you're going to go. So people who are cases, we call them and they're, well, I wasn't feeling so great, but I went in anyway. And we're like, why'd you do that? So again, emphasizing those for everybody. We can all make choices that safeguard the people around us, and they're not hard choices. I mean, it's inconvenient. Sure, you want to go to that event, you want to see your friends, but we can make some choices and enable us to keep things open and bring these numbers down at the same time.
Dr. Buchanan, the thing I'll add to that is that the other thing people may not think about is it's that moment where discipline is so important here, because that moment where you let your guard down, it might not ultimately affect you. You could end up transmitting COVID-19 to someone you really care about, and then they could end up in the hospital. And so, and it wasn't anything, there was no ill will or ill intent. It's just, just that period of time where you weren't being as careful. And then, it's not just affect you, it could affect somebody you really care about. And, we've continued to see some really unfortunate things on the hospital side that will just break your heart. And it's not because anybody, willfully did anything wrong. It's just that it somehow it just played out. And I think our best defense are the 5 core actions.
And one thing I'll say, given that we're talking about our order and where we're at, I think we need to kind of stay the course right now. We're starting to get to the point where we might see the benefit of what we've ordered. We need to encourage those 5 things for everybody to do as best they can. And just to follow through, keep watching the numbers. Let's see where we're going and see if this will really make a big difference.
Any further discussion on COVID-19 face covering regulations review? Anything else that anybody would like to bring up?
I have a question. Just this may be as much for my education as anything else, but we've referenced the emails that we received. And Dr. Buchanan, this may be kind of partly for you, but certainly there have been some very passionate, well-written emails about the school and the reopening and things like that. And so I just want clarity both for myself, but then also for anybody who might be watching, is that, and this even came up in one of our meetings a few meetings ago, but this Board of Health doesn't have any direct authority in any way over the Knox County education, and other than hopefully they're watching what we're saying and doing, but it's not that we have that decision-making ability. Is that correct?
That is correct. So, in my position, we serve in an advisory position or role to the schools, and have done that for years. Ultimately, it's the superintendent and the Board of Education's decision what school policy is and about, student attendance and all those things. And so we are actually, right now, we're meeting, and for the foreseeable future, we'll be doing so. We're meeting weekly with Knox County School Administration folks on Thursdays. It worked out well because we have this meeting, benchmark, so we'll meet with them and present the benchmark data and, maybe some other specific information that we have about, zip codes or areas in our community where we're seeing more cases, so that they can make decisions about how to move forward with the schools.
Very good.
This may be a good time. I did put something up for all of you just before the meeting related to this, because I've been kind of concerned about the schools. I know we don't have a say directly, but we can recommend to the schools and try to be of help to the schools. And so I've talked to a few folks, and I put together just a recommendation that I'd like to see if we could bring up and look at. And basically it utilizes some of the same gating criteria that we've seen done. I've looked around the state. Hamilton County and Anderson County have gone to a system, and it just advises the administration to think through different aspects. That's one of the things I'm hearing a lot of, is just people are really concerned about their kids, about the caregivers, families at home, and they would like to know that schools are getting the best, recommendations as possible. So what I put together is just a recommendation. It's not a must-have or anything, just to help them. That is color coded and follows something that Hamilton County and Anderson County have both done, but utilizing the school's own system of what they've kind of set for their gated reopening. So here's an example of Hamilton County on the left and what they've done, and it just shows phases. And what they use on the left side there are their active cases, and they do a percent of population, and both of them do it that way. If you look at Hamilton County, they go from phase 4 to phase 1. If you go to Anderson County, they go from phase 0 to phase 3. Anderson County's updates itself automatically on their website based on data that they get daily. What I would like to propose, and I have an actual recommendation, we'll go to the second part of that where it says example, if we can move down to that, is to kind of do the same thing, taking what the schools have already started working on and just to kind of give a guideline, a suggestion of things to think about, and then could always work with us as they are working with Dr. Buchanan and the staff, and even if we as members of the Board of Health need to help in any way to try to work through this. So if we go to the last one, this would show exactly where we are today. And this is taking basically our numbers of active cases and taking those based on our population, look at the active cases per 100,000. So, I mean, you just take the number of cases, which was 1392, you multiply by 100,000, divide by our population of 470,313, and you come up with 296 per 100,000. So this would put us kind of in the middle, which is where the school system is, they've been planning for, and they have, I think, really good plans, hopefully, for. And it also has transition zones above and below where you look at the things like the teacher and student absences, how many people are hospitalized, how are the ICUs doing, what's our positivity rate. So it just kind of is a way to look at it. I do have this recommendation written up, if you could show that, please.
Before we move on, can I make some comments on this data? Is that okay?
Please do, and let me know if this makes sense
Okay.
at all, Dr. Buchanan, please, and if we should even proceed based on what you're working on.
So my first comment is positivity rate is not a reliable number in our current state. We've talked a ton about, we don't really know the N for our positive cases. Our positivity rate is really not reliable. So I wouldn't recommend that we use that. And I guess my question is, and I've looked at the stuff from Anderson County and Hamilton County, and I think Williamson County is doing this, and actually reached out to Hamilton County Health Department, just curious because she's one of the other metros, and she and I have been talking a lot lately, wondering what role they're playing in helping them with this data, and they're not. They give them data, but they didn't help them create this gating system. I don't know where the gating system came from. I don't know what the science is behind this gating system. So that's one of my concerns with this is I don't know what the science is behind it. And I don't know if anybody knows what the science is behind it. And I also would like to, we talked with the schools yesterday, and we would like to continue using our current benchmarks plus the benchmarks they use, which are in their plan, so that we don't have to have any more data. Honestly, I can't ask my staff to pull any more data than they're pulling. I'm just being really honest. You heard me earlier say we're starting work at 5 a.m. and that's so we can get things going and get a hold of folks in a timely fashion. And those are the same folks that are also pulling my data once people start calling cases. So what we agreed upon, and if we want to, I don't know, we can look at your resolution, but really was to use our current benchmarks plus the benchmarks they use for flu all the time. Teacher student absenteeism, substitute fill rate. They have to look at that. Lisa, correct me if I'm wrong, because that's what I remember.
Great.
And frequently the Achilles heel for the schools is that substitute fill rate. I think it's helpful to have some guidance, and what we don't want to do is we don't want to end up backing ourselves into a corner and we go, oh, we're at this many cases, we have to close all the schools. Well, all those cases are in, a bunch of those cases are in one industry where we have a big outbreak in a company. And so we hit this mark and we're closing schools because we have an outbreak in a large company. That I wouldn't, and I've spent some time thinking about this since last week or whenever it was I saw it the first time. And I just, again, have some concerns about that. We set this benchmark and we get there, and the reality is a lot of those cases are, like if you look at the counties where they have outbreaks in the jail or in their prison system, certainly it impacts the community when those folks get released. But if you were to choose to close schools because you had 600 cases in the prison, we don't have a prison, but again, I just have concerns. So we are definitely talking with them regularly, and we have a plan for moving forward on that. And I believe we'll have some more information coming out, because I know the way they wrote their plan and when they put it out publicly, consultation with the health department wasn't really strong and wasn't well defined. And so we're working on defining that with them so that the community will see that we are using our current data to provide guidance for the schools. So those are just my comments about the gating
And I
criteria.
would add just real quick, the hospitalization piece, the ICU piece, that's already in what we're looking at and doing standard deviations on the change of that for our benchmarks every week. So I think that one, I feel good about that those are also captured as well, which is kind of where we lean to where we were leaning towards just using our benchmarks for that. And then also, just to be upfront, any other data that we talk about here, we'll talk about with them, the next day as well, was kind of the addendum on that, what we talked about yesterday.
And I think the other thing, one of the reasons when we put together our benchmarks, we didn't choose an absolute number because there's so much nuance. Again, I keep going back to the cluster example, but if we have a large cluster, especially when our numbers were really low, we'd have a large cluster in a construction site and it'd pop our numbers up, but it was really a large cluster in a construction site. And so it wasn't community widespread. We're beyond that now, but at times it's been like that. So those are just some of my cautions about setting a number and saying we're going to do something based on that number.
Right. And again, this just came up talking to some other people who, have kids. I don't have young kids in the schools anymore, but talking to people, they wanted to make sure that we as the Board of Health and as Knox County Health Department had more of a say, and they wanted to make sure they heard that they were seeing that projected. And as you said, it was kind of a minor, kind of the last thing on the list. So that's where that came up. And so when I started talking to a few people, this came about talking to two specific people who really wanted to bring this up. I said, I'd be happy to bring this up, and that we need to make sure that the discussions are ongoing, continuous, and give parents a feeling of safety going forward. And one of the things that did come up in the discussions I had with these folks is we have August 17th as the day to open schools. Their concern was, if something happens between now and August 17th that our numbers keep going up, will somebody be able to advise and hopefully get something done that could maybe put it off 1 week, 2 weeks, if that's what would be needed, so that you would open up the schools and keep the schools open, versus being hard pressed to open on a certain day just because you've said that, and then end up having to close the schools because numbers kept going up and would spread. So that's where this comes from. And, again, I just want to bring up for discussion. I did write up a resolution, but I'm happy to go with whatever you and your staff can do. And if that's the way you feel that it needs to go, then that's the way we can go.
Dr. Buchanan, I would assume that a key part of the epidemiology as the school opens would be to track school age groups very carefully, and also do very careful contact tracing on those groups. And I'm sure you already have that in place, but your thoughts on kind of watching that more narrow demographic groups as the schools open.
Well, I'll be honest, school absenteeism is going to show us more about what's going on than case positivity stuff. Our labs are going to lag behind school absenteeism. School absenteeism is almost real time, or is it real time, Lisa?
Yes.
Yeah, so school absenteeism, teacher absenteeism, substitute fill rate, that's all real-time data that actually is going to show us more about disease burden in our schools than case positivity rate in those age groups. Case positivity rates in those age groups is part of that. It's not the full picture though, and it's not the most up-to-date data. And Lisa can talk to it as well, but we have a plan with the schools for them to be helping with our contact tracing for cases among staff, teachers, and students. There's just going to be extensions and working with us. Lisa talks to us a lot these days, and that's fine. But the volume is going to be increased, definitely. But we work with the schools year in and year out when they have cases of meningitis, salmonella, you name it. We work with them when they have those cases in the schools to appropriately close the parts of the school that need to be closed or send the kids home that need to be sent home. And I'll be honest, we will take kind of a more surgical approach to this, as we have done with daycares and successfully done that. If a child care facility has an area where these kids are here and they're always here and they don't go there and those teachers don't go there and they get a case there, then we can just quarantine that classroom or that section and not have to quarantine the whole school or the whole child care facility. And we've successfully done that and not had continuous cases in those child care facilities. And even in nursing homes, we've done the same. So, I think we probably need to let the community know more that we are working with the schools and how we do that. And I think there's a communication piece to that as well. And I've read your resolution, Dr. O'Brien, and I'm wondering if we could amend it to say what I think is more appropriate for us to do, because when I read this, there also is some extra data stuff in there that we're not currently doing. And the schools, they'll have to see if the schools want to publish their absenteeism data. I'm not sure they'll want to do that. Lisa, I'm not sure about that. We certainly, all of our data is out there in public.
And I would say, just to jump in real quick about the age groups, we do think there'll be a lag, and absenteeism will show quicker than the lab results, but we absolutely have the breakdown by the age groups and can talk about that. We have the 10-year chunks, but still we can have a picture and we'll be able to provide that and that's on our website as well, actually, but we can highlight changes in that data when we have those discussions from what's updated regularly anyway.
It's one of those things that the reason this transpired is because unfortunately we can't talk to you, Dr. Buchanan, directly like we would normally do, because the thought would be we might be trying to make some decision behind everybody's back, the public's back. So that's the unfortunate aspect of this, where people come to me, talk to me, know that I can't talk to you, and say, well, would you bring this up in a public way so that we could discuss it? So that's what this is. This is people's concern out there. Some very passionate people in our community who spent time to get hold of me, to work on this, to try to show that they care about their kids, and we all do. We all care about our kids and our families and everybody. So we could either take what was written with a lot of whereases that kind of speak to each of the areas that we've been dealing with, a lot of the statistics, or we could just hold and go with what you're doing. But just to reiterate to the public, it is being worked on. It is important that decisions will be made with good data, with evidence, and that we want the schools to understand that we stand ready to help, and that you definitely stand ready to help, you and Charity and the rest of the staff. But I just want to make sure, I don't want the people who help work on this to feel like oh, we're letting them down because we're not passing a resolution. But we are trying to look at this and make sure that we are staying on top of it.
I mean, the other thing that is another way boards and others communicate with legislatures and let them know what the concerns are is just a letter of support from this board that would go to the Board of Health, not the Board of Health, you are the Board of Health, to the Board of Education, saying, you know, we support you working with, you know, Dr. Buchanan and her team at the health department using the current benchmarks to, you know, or encourage the superintendent, or however you would want to say that. And that's another way to do that. It's not a resolution. It's just a letter of support saying this is our even a recommendation, however you want to word that. That's something we could do that could get written up and pretty easily and in support of what the schools already do with us. I don't know how you feel about that. And then the other thing, Lisa, I'm picking on you. You know, if the superintendent were okay with it, Lisa could certainly update this body, and then we could update the Board of Education as well as needed on, you know, what's going on.
Sure. I think they would welcome that.
Mhm.
And my original question, which was just truly related to emails that I had received, is that I didn't perceive myself or in the emails I'd received that level of connection. So, and again, like Dr. O'Brien said, I couldn't just pick up the phone and call you and necessarily ask you about it. And so I think that any way to formalize that, because if it's happening, everybody needs to know it's happening. And also, from a data sharing perspective, whether it be a general report of absenteeism, all these kind of societal trends are going to help guide decisions. And that's in the same way I'm showing you hospitalization stuff, because ultimately that could affect the schools if it got significant enough. You know, there's no question when hospitalizations are really significant in other cities, we've seen that guide decisions, but it's all so interconnected that we really can't be looking at anything just by itself in a vacuum. We've got to be thinking about all these things as they relate to public health together. So Dr. Buchanan, I would support the approach you just said. And one other thing I'll just say, Dr. O'Brien, to help kind of, I know that some very passionate people brought this to you. What we found on the hospital side is that sometimes these things are so nuanced that anytime we've tried to set any sort of cutoff, it's not something we felt we could related to COVID-19. It's very hard to put a line in the sand, but it's one of those things that when you're there, you know, at least when you're headed in that direction, you kind of sense it and know it.
I appreciate it, and I'm hoping that the people listening understand that we will go this way, and knowing that the health department is working with the schools and is so stated. I think us putting a letter out would be a good thing to do. Maybe we could write something up so that next week we would have something to affirm and to go forward with. So we just want to show that we're all working on this together and doing all the 5 core principles and that we are all of us in this together.
We are. And
Can I say
yeah,
something?
sure, Lisa.
Oh, I just wanted to say that Knox County Schools has a wonderful relationship with the health department. And we think very highly of Dr. Buchanan and her staff. And we would not do anything to jeopardize children or the staff. I just wanted you to know that. And so I do take to heart what you said about, you know, communication and things like that. And so maybe we can work that together with, you know, if you want a meeting or something like that or whatever. I just wanted you to know that Knox County Schools values our partnership with Dr. Buchanan and her.
Lisa, you're going in and out. And she's gone. And she's gone.
personally think that it'll be a good idea to send a letter because I get a lot of questions about that. They think we're in charge of the opening of the schools, and to get it out there that we are here to help the school board is a good idea.
Dr. Buchanan, I think there were a couple of articles in the media this last week that almost implied the opposite. I know when I read them, that was kind of my take on it. And anything we can do to publicly get that out, that actually that's not the case, that there is a high level of communication and cooperation, I think that'd be very useful.
And we can do that. And I think the schools, I think we put a statement out yesterday, with a joint statement out yesterday with the schools, saying that very thing, that we're working together. Yeah, that was, anyway, there was a very direct question asked of me, and I answered it honestly, and it was taken to imply that we weren't working with the schools. So. But we are.
So we are at a point probably still in other business right now. Is there any other business that we need to go over at this meeting? If there's not, we can entertain a motion to adjourn and plan on meeting in about 1 week from now. Any other discussion that we need to have? Are we good for today?
I move we adjourn.
Second?
I second it.
Okay, I think we are set to adjourn, and thanks everybody for your input and help with this. I think we have had good discussion today, and we'll get updated in about 1 week then. Thanks, everyone.
Thank you.